This is the continuation of the Addiction 1 video. The reuptake of dopamine into the presynaptic terminal occurs through the gated dopamine transporter and there is metabolized by monoamine oxidase in the presynaptic terminals. Dopamine transporters also carry serotonin and norepinephrine. Cocaine inhibits or blocks the dopamine transporter. So cocaine also blocks the uptake of serotonin and norepinephrine. Inhibition of serotonin uptake by cocaine may also contribute to psychostimulant effects of cocaine. The mechanism of action alcohol. Alcohol is a CNS depressant and it decreases the respiratory rate, heart rate, and the temperature, and also produces euphoria and addiction. For addiction, alcohol doesn't have a specific receptor site to act. Instead, it acts on many receptors. It acts on dopaminergic neurons, the glutamate, GABA, opioid, and serotonergic neurons. It stimulates the dopaminergic neuron in the VTA and nucleus accumbens and also stimulates GABA receptors and GABA neurons in the CNS and opioid receptors. It inhibits the glutamate receptors and serotonergic receptors. The glutamate is the excitatory neurotransmitter in the brain. It acts by increasing the sodium influx into the neuron, and it acts by three ionotropic receptors, mainly through NMDA. The other two are AMPA and kainate. Remember, NMDA receptor requires first the firing of AMPA receptor to start firing because it has a natural blockade by the magnesium ion. The glutamate receptors project from the frontal cortex to the nucleus accumbens, and these fibers they terminate on the medium spiny GABAergic neurons in the nucleus accumbens. From here, nucleus accumbens, the GABAergic projections they go to the ventral tegmental area VTA. When GABA is produced, the dopaminergic neuron in the VTA which project back to nucleus accumbens, they are inhibited. But alcohol it inhibits the glutamatergic neurons or projections to the nucleus accumbens which project on to the GABAergic neurons to stimulate. But when glutamatergic neurons are inhibited, the GABAergic projections to VTA do not produce GABA in the VTA, which is inhibitory to dopamine or dopaminergic neurons in the VTA. So this is a kind of disinhibitory mechanism where GABA is not produced, so dopamine is produced. This is the prefrontal cortex. From here, glutamatergic neuron projecting to nucleus accumbens, and then they project the GABAergic neuron projecting to the VTA, and from VTA, the dopaminergic neuron project back to the nucleus accumbens to produce dopamine and euphoria. So alcohol inhibits these projections, glutamatergic projections to nucleus accumbens. So these GABAergic neurons are not stimulated to produce GABA. So absence of GABA increases the production of dopamine by the dopaminergic projections in the nucleus accumbens. The depressant effects of alcohol arise from its action on GABA receptors, the GABA A receptor, the principal postsynaptic receptor or inhibitory neurotransmitter of GABA. The GABA opens the ion channel for chloride ions and causes influx of chloride, hyperpolarizing the membrane and decreasing the chances of action potential to occur. However, the chronic use of alcohol results in a decreased sensitivity of GABA receptor to both alcohol and GABA itself. Remember, alcohol is inhibitory to the central nervous system, but by stimulating the GABAergic neurons, but it inhibits the GABAergic neurons in the nucleus accumbens because it inhibits the glutamatergic neurons which project from the medial frontal cortex to the nucleus accumbens. The GABAergic neurons in the nucleus accumbens are stimulated by glutamatergic projections from the prefrontal cortex. So the mechanism of GABA action is increased chloride conductance. The same mechanism is by the benzodiazepine, barbiturates and alcohol. They stimulate the GABAergic neurons. In experimental animal, GABA agonist muscarine terminates the self-administration of alcohol when injected in nucleus accumbens. So with acute alcohol injection, the action is that the excitatory action of glutamate is decreased and it increases the inhibitory actions of GABA. But chronic exposure to alcohol reverses the situation. The glutamatergic neurons become hyperactive and GABAergic neurons become depressed because the glutamatergic receptors are increased and GABAergic receptors are decreased in chronic alcohol use. So it produces an excitatory symptoms in chronic alcoholics. Abrupt cessation of heavy drinking leads to increased glutamate function together or combined with a corresponding downregulation of inhibitory GABA function, causing brain hyperexcitability, characteristic of acute withdrawal syndrome. The withdrawal triggers the hypothalamic pituitary axis in an increased CRF, leading to increased production of cortisol, which can kill neurons in hippocampus, promoting disorders of mood and intellect. The alcohol stimulates the release of endorphin by stimulating the mu receptors, the opioid mu receptor, and cause euphoria and analgesia. Opioid blockers reduces the craving for alcohol, and this has led to the FDA approval of the drug naltrexone, a drug that interferes with the function of opioid receptors as a treatment for alcoholism. What alcohol does that it stimulates the mu receptors in the nucleus accumbens. These mu receptors are present on the GABAergic neurons in the nucleus accumbens that project on to the VTA. A stimulation of mu receptors by alcohol inhibits the GABAergic neurons that project on the VTA. So inhibition of GABAergic neuron increases the dopaminergic neuron or dopamine production in the nucleus accumbens. So this is also a type of disinhibition. Studies show that alcoholic rats have fewer serotonin releasing neurons in the hypothalamus. Number 2, they have higher levels of opioid peptides in the hypothalamus. Number 3, they have more GABA neurons in the nucleus accumbens. A lower level of serotonin metabolites in a CSF of alcoholics have been shown to be lower than normal. Alcoholics given serotonin and dopamine precursors in clinical trials reported fewer cravings for alcohol, less stress, and had an increased likelihood of recovery and a reduction in the relapse rate. However, the chronic alcoholic, there is a decreased sensitivity of GABA to both alcohol and GABA itself. Alcohol appears to actually change the genetic makeup of the neuron and thus changes the structure of receptor, and this increases the tolerance and leads to withdrawal syndrome if the drug is stopped. The mechanism of action of opiates. The opiate receptors are G protein coupled receptors. The two main opiate receptors, mu receptors and the kappa receptor, are exactly opposite in action to each other. Mu receptor stimulation produces euphoria. They activate the G protein that inhibits the adenylate cyclase, that decreases the cyclic AMP and then decreases the cyclic AMP dependent protein kinase. The mu receptor activates the potassium channel and inhibits the calcium channel, thereby hyperpolarizing the neuron. Whereas the kappa receptors, they produce dysphoria. Remember, mu receptor stimulation produces euphoria, and now kappa receptor stimulation produces dysphoria. Opioids binds to the mu receptors in the nucleus accumbens. That inhibits the GABAergic neuron, and these GABAergic neurons projects onto the VTA and disinhibit the dopaminergic neurons. This increases the firing in them. So stimulation of mu receptor inhibits the GABAergic neuron that project on the VTA, and inhibition of GABA increases dopamine production in the nucleus accumbens. The mu receptors are predominantly on the GABAergic cells in the nucleus accumbens. They hyperpolarizes the GABAergic neuron, inhibiting them, and by disinhibiting VTA dopamine neuron, increasing the dopamine release and euphoria. The kappa receptor, on the other hand, they are mainly located on dopaminergic terminals in the nucleus accumbens. So the kappa receptor inhibits the dopaminergic neurons, so they decrease the production of the dopamine, and this produces dysphoria. The opioid receptor activation generally inhibits the individual neuron, that it is a CNS depressant. What is opioid adaptation? The chronic opioid use increases the cyclic AMP signaling in locus ceruleus. So increased cyclic AMP signaling leads to adenylate cyclase activation, cyclic AMP, protein kinase, and CRABEB, which is the principal adrenergic nucleus. Locus ceruleus is the principal adrenergic nucleus in the brain and regulates attention and autonomic nervous system. Locus ceruleus is hyperactive in opioid withdrawal. The opioid NMDA antagonist dextromethorphan have been shown to clinically to reduce the withdrawal symptoms, drug craving, and relapse to heroin, cocaine, and ethanol. A brief review of the opioids are morphine and heroin. The difference between morphine and heroin is that heroin is similar to morphine but is an ester of morphine but is an inactive form. It does not act itself, but it's lipophilic, so it crosses the blood-brain barrier easily, and then when it enters the brain, it is converted back to morphine, and then it acts as and it produces high. The morphine, the heroin products high or a rush by injection, insufflation, whereas morphine does not produce a rush or a high because of the first pass metabolism in which 50% of the morphine is metabolized. The heroin produces high or a rush by three routes: injection, inhalation, and insufflation. The cannabinoids. The active ingredients of cannabinoids is 9-tetrahydrocannabinol. 9-tetrahydrocannabinol increases the dopamine in the nucleus accumbens and euphoria, and this is blocked by cannabinoid receptor antagonists and by mu opioid receptor antagonists administered in VTA. This suggests that both opioids and cannabinoids, they share a common signaling pathway and promote each other's reinforcing properties. Nicotine. Nicotine acts on nicotinic cholinergic receptors in the VTA and thereby increasing dopamine in the nucleus accumbens.